Hello, I'm Clyde, an MD radiologist practicing in Bangalore, and this session is on previous year questions in the NEET PG exam brought to you by the Global Health Academy. First off, you've been asked to identify the imaging modality given to you. Is this a cerebral blood flow scan, a PET CT or a positron emission tomography CT, a SESTEM-EB scan, or a full body MD-CT? So to understand this, we'll go over the options. Is this a cerebral blood flow scan? Obviously not, because the whole body has been represented in the image given to you. On the other hand, a cerebral blood flow scan looks something like this. It predominantly images the brain parenchyma and is trying to assess perfusion in different parts of the brain. A SESTEM-EB scan is something like this. It's a low resolution scan where the tracer SESTEM-EB is concentrated in the parathyroids. So if you have a parathyroid pathology, you use a SESTEM-EB scan for the parathyroids. A cerebral blood flow scan is for the brain itself, all right? And your image has a fusion of both CT, as evidenced by the hyperdense bone here, here, and also here, superimposed on which is a representation of metabolic activity. So all of these color areas are PET related and they signify metabolic activity in various normal tissues. So there are areas of physiological concentration of the tracer that you give. Most often it is 18 FDG, and therefore this is also called an 18 FDG PET fused with a CT, so a PET CT scan. All right, so our answer here is a PET CT scan. A full body multi-detector CT or an MD-CT, multi-detector, all right, that's basically the technical name given to it, the technical term associated with it. A full body MD-CT will look similar. It's the entire body top to bottom, but it will not have a representation of the metabolic activity because a tracer has not been administered. You can perform this one on a commonly available CT scanner. This one requires a PET imaging suite. All right, so our answer here is a PET CT. Okay, this patient has been brought to you following a road traffic accident. He's conscious, he has a blood pressure of 90/60, his respiratory rate is 40 and his heart is beating at 120 per minute. So the X-ray has been given to you and you've been asked to decide on what the next best step is. Are you going to put in a chest tube? Are you going to perform a pericardiocentesis for this patient? Will you do a thoracotomy or will you perform a pleurodesis procedure? So to understand this image, we will first look at a normal image because you've assumed that this is pathological. In a normal image, you will notice that the trachea is central, the bifurcation into the carina appears, normal into the right and the left main bronchi, the mediastinum shadows appear normal. These are the mediastinum shadows. Both the lungs appear fine. This is the right and that is on the left side. The diaphragms appear intact and all the bony structures that you can see are normal. You can see vascular markings in both the lungs, in the upper and the lower. When you compare that with your case image, you will notice that on the right side, there is a little bit of rotation in this X-ray. When you look at the right side, there is some opacity in the lower zones, but when you look at the left side, you see a layer like this, and you see no vascular markings in this side. So this is the border of the collapsed lung, and this area is filled with air. When you have air in the pleural cavity, this is called a pneumothorax. All right, when you have a pneumothorax, you need to relieve the pressure because there has been an injury or an insult somehow, either from outside or from the lung parenchyma. Air is getting in between the pleural spaces and forming a pneumothorax. So your question then looks at a thoracotomy or a pleurodesis. Are you going to perform either of those? In an emergency situation, you wouldn't want to perform a thoracotomy because that involves opening the chest up. All right. A pleurodesis is basically sealing off the pleural cavity. You instill something like chalk that irritates the pleura and causes a complete occlusion of the pleural cavity, which is not something you're going to want to do right now in an acute scenario. A pericardiocentesis, obviously it's in the name, pericardio pertains to the pericardium overlying the heart. You will perform a pericardiocentesis when you have a pericardial effusion. You obviously know that there is a pneumothorax here, and therefore the most appropriate is going to be a chest tube insertion. The procedure for a chest tube insertion is outlined here. You will nick the skin after administering local anesthesia, dilate the tract that you've made, insert a finger till you reach the pleural space, followed by trocar guided administration or enabled administration of a chest tube. The chest tube then faces apically and drains the air out into a seal, or under a seal rather. Your next question is pertaining to a 2-month-old who's been brought to you with a parietal swelling since birth or shortly after birth. The X-ray image has been given and you've been asked for a probable diagnosis. Is this a subgaleal hematoma? Is this a cephalhematoma, a caput, or an encephalocele? So now we look at the various options given. The most striking among the options and visually when you look at a child is this. You notice a large protrusion from some part of the skull, either the anterior, the vertex, or in the occipital region as we see here. So when you look at a cross-sectional MR image here, you notice that there is a parenchyma herniating into a defect seen in the occipital region. When there is parenchyma, brain parenchyma, and herniating out, this is called an encephalocele. And depending on the area, it is given a name, occipital in this case, because the defect is in the occipital region. So the defect is over here. There is an occipital encephalocele. There are various forms of hemorrhage that can affect the cranium of a newborn. You can have extradural hemorrhage starting from inside, which is outside the neuraxis. It's outside the brain parenchyma and the subarachnoid spaces. You have an extradural hemorrhage. You can also have a cephalhematoma, which is essentially between the cranium and the bone. You can have a subgaleal hemorrhage, which is between the layers of the scalp, and you can also have a caput, which is in the soft tissue of the scalp. This is a pressure dependent collection. It can occur during molding and the birthing process itself. So these are the different layers and these are the different hemorrhages that you can have. You will notice that the periosteum binds a cephalhematoma. So a cephalhematoma will not cross a suture. A subgaleal hematoma, however, is present over that and can cross a suture. Now, in our question, we have something that doesn't obviously appear to be crossing a suture. It is present over the parietal bone and is therefore cephalhematoma, not a subgaleal, not a caput, and not an encephalocele, because then you would have to see a defect in the bone for brain parenchyma to come out. After this, you've been given another radiograph or an X-ray. You know this is an X-ray, all right, and you've been asked to identify the diagnosis. So the patient had abdominal pain, sterile pyuria, and the following features on the X-ray. So are you looking at a putty kidney? Is there nephrocalcinosis? Is there a Staghorn calculus? Or is this psoas calcification? So you have to first identify the pathology. You're looking at the lumbar spine, the lumbar vertebrae, the sacrum over here with the sacroiliac joints on either side, the ilium on both sides, abdominal soft tissue. So you see the psoas muscle shadow over here and you see a abnormal opacity which is asymmetrical. It is not seen on the opposite side. You don't see it on the left, you only see this on the right as the marker would indicate. Alright, so when you have a radiograph which is showing you opacities on both the sides, you are very often looking at some sort of systemic issue that has become symmetrical and bilateral. So if you have a systemic problem, you are most likely to have a symmetric pathology which is bilateral. Alright, there can be some degrees of asymmetry like here and here, but it is going to be a bilateral pathology or phenomenon. It's going to involve both the kidneys, right? The left kidney and the right kidney. This becomes nephrocalcinosis. So if you imagine this to be the outline of the kidney, there is calcification in the renal parenchyma. Alright, so this becomes nephrocalc. When you look at another option, you have a radiograph of the abdomen. You have the lumbar spine, the pelvis, and you have these opacities in the region of the kidney. So you assume the kidney is over here, and you can even see the outline of the collecting system. So if I tell you that this is a non-contrast X-ray, no contrast has been administered, you will have to assume that this is going to be a calculus. It is a radio-dense calculus or an opaque calculus, a radio-opaque calculus. When this patient was operated, this large calculus was removed. This is not ginger, this is a calculus. Alright, a calculus was retrieved and this was a Staghorn calculus. Staghorn. Alright, so this is the term given to this peculiar form of calculus, a stone that extends from the pelvis into the collecting system and also a little bit into the ureter, and a fragment on the opposite side has landed up in the distal ureter as well. Now what sort of image is this? This is an axial image of the abdomen and is a CT scan. Alright, so the bone is hyperdense, fat is going to be hypo, and soft tissue of various forms are going to have differing densities in between. All right. Now you have arrows pointing to the paravertebral space. Now you know that the musculature in this region is the psoas major muscle, and inside the psoas major you see hyperdense content or radiodense content. This becomes calcification. So coming back to our question and the image accompanying it, you are not looking at nephrocalcinosis. There is nothing on the left side. A Staghorn calculus is not present because the orientation is not similar to a Staghorn, and a psoas calcification is not seen because you can see the psoas shadow very well. In our country, we assume a lot of pathology to be secondary to tuberculosis. So when you have genitourinary tuberculosis or end stage TB of the kidney, you can end up with what's called a putty kidney. Alright, so all the viable parenchyma has been displaced, and you have a calcification that occurs in the parenchyma and the collecting systems, leading to what's called a putty kidney. Alright, so what you're looking at is a putty kidney secondary to long-standing genitourinary COX or tuberculous infection. The next image given to you in the next question is a child with limb deformity, multiple bone lesions, and cafe au lait spots. A radiograph was obtained of the left lower limb, this is the left side, and it showed a ground glass appearance of the bone. So what pathology are you looking at? Is this a non-ossifying fibroma, a fibrous dysplasia, Paget's disease of the bone, or osteogenesis imperfecta? Now you know that osteogenesis imperfecta is going to be sometimes seen in isolation. One of the most striking features is the blue sclera, which is not mentioned in our clinical STEM. He has a whole lot of other issues. Limb deformities which can be seen, yes. Multiple bone lesions, these may also be seen, but they are not lesions, they are more fractures and repeated number of them. Multiple fractures which heal and fracture again. So you can also have cafe au lait spots not seen again in osteogenesis imperfecta. So you have multiple fractures which are not seen in our current situation. So we rule out osteogenesis imperfecta. When you look at the next conditions, you have the bone. This is an immature skeleton because you can see the growth plate open. This is the left lower limb. You can see the tibia and the fibula, in which you see an area of lucency with a relatively sclerotic border. Now this is something that is not ossified. This is a non-ossifying fibroma. Alright, so a non-ossifying fibroma looks something like this. Here you see the lumbar spine, where you see the vertebral bodies, and you notice that one of these vertebral bodies is much denser than the ones above and below it. So sacrum over here. So this vertebra is much more dense. Keep that in mind. On the other side, you see another lumbar spine where you have normal appearing vertebral bodies and one vertebral body with a thick rim and an area of relative lucency in the middle. So this is what you call a picture frame. It looks like there should be a picture inside it, a picture frame and an ivory vertebra. So ivory, like the tusks of elephants, are extremely dense. So ivory vertebra, because this is much denser than the ones above and below it, and a picture frame vertebra because it has this dense cortex with a central lucency in the middle of the vertebral body. So now when you go back to your question, you have a fibrous dysplasia, which we've not seen, a non-ossifying fibroma, which we've seen in the tibia, and Paget's disease of the spine, giving you the ivory vertebra and the picture frame vertebra. So in light of your clinical STEM with cafe au lait spots, multiple bone lesions and a limb deformity, you're probably looking at a McCune-Albright syndrome or fibrous dysplasia being the bone lesion. Alright, this one is peculiar because it has this hooked appearance, also called the shepherd's crook appearance. So this is another buzzword that you can hear. This is called a shepherd crook or a shepherd's crook appearance, which is basically a shepherd's staff or a stick, all right, which he uses during his work. So a shepherd crook appearance of the femur in this case, which is because of the fibrous dysplasia. All right, your next question is someone who's presented with chest pain and hoarseness of voice for 1 month. The CT angiogram has been given to you and you've been asked for what are the possible diagnoses. Now, when you think of hoarseness of voice and your question is leading you to a CT angiogram, you are thinking of something that's affecting the recurrent laryngeal nerve. When you think of the recurrent laryngeal nerve, your radiological anatomy will point you to the arch of the aorta on the left side. All right. So if they had, say, video laryngoscopy findings in the question, it would give you that the left side of the the vocal apparatus is abnormal. So maybe the vocal cord was paralyzed or was not functioning properly. The minute you see that, you have to look at the arch of the aorta. Can a stenosis of the aortic arch cause a nerve compression? Not really. The vessel is in fact narrowing up to a point and then dilating. So it's not going to be something that's exerting pressure outward. It's an inwardly directed phenomenon. An aortic dissection, again, is going to be a flap that's created in the intima within the lumen of the vessel. This is not going to exert significant pressure in the outward direction. It is a problem inside. It can cause problems when it extends into the branches or compromises the lumen. Coarctation of the aorta, similar to stenosis. When you have the aortic arch, is going to narrow up unto a point and then dilate from there. You can get notching of the ribs and other conditions, but you will not get an outwardly directed phenomenon. If you have the recurrent laryngeal nerve passing close to the aortic arch and there is an aneurysm or a protrusion or a bulge from the lumen of the aorta, that can cause a recurrent laryngeal nerve issue and thereby cause a hoarseness of voice. So in the volumetric reconstructed image and the MIP images, you can see that there is a protrusion from the arch of the aorta, probably compromising the recurrent laryngeal nerve and giving you hoarseness. So your answer here is a saccular aneurysm of the distal aortic arch. You can see the ascending aorta here, the arch of the aorta, the branches of the arch. The last one becomes the left subclavian, and following which you have the descending thoracic aorta. At this point of transition, you have a saccular aneurysm. You've been given a radiograph of a child who's swallowed a foreign body. So there is a foreign body in the esophagus. What term is used for this sign? So which of the following signs has been represented? When you look at the lateral radiograph in an adult with epiglottitis, you will get a bulky epiglottis that protrudes like a thumb. Alright, so this is called a thumb sign. This is a thumb sign that you see in epiglottitis. When you have acute tracheobronchitis, acute tracheitis, you get narrowing of the trachea in the cranial aspect because of edema. This is likened to the steeple of a church or one of these older constructed buildings. So this is a steeple sign. Following which you can also have the string sign which is seen in bowel pathology. Basically in the terminal ileum, you see a significant narrowing and a string of contrast, barium contrast transitioning from the ileal loops into the cecum. So this is called the terminal ileum string sign or string sign of Cantor, which can be seen in Crohn's disease. So our question was not indicative of a thumb sign seen in epiglottitis, not indicative of a steeple sign which is seen in tracheobronchitis, and not a string sign which was seen in Crohn's and sometimes terminal ileal Cox or tuberculous involvement. So it's neither of these. So what we're looking at is a double ring sign. Now a double ring sign is alarming and you have to pick it up because the zoomed in version here shows you two concentric rings. Now this is going to be seen in lead battery or button battery, lead button battery ingestion. Okay, so when a child swallows one of these and they get stuck in his esophagus, that is going to give you this double ring sign. You have to look carefully because a coin, you can wait for it to pass. It's going to be relatively inactive or inert. So a battery can corrode or erode under the presence of or in the presence of gastric acid. So if this erodes the battery can cause significant compromise to the gastric or the esophageal lumen and can give you a perforation. All right. So a button battery is a emergency and has to be retrieved. All right. When you're looking at the CT image given to you, you've been asked to identify the likely etiology. The patient had severe headache, NCCT and CT angiography images may be shown. I've given you a CT, plain CT image. Are you looking at an AV malformation, a subarachnoid hemorrhage, an intraparenchymal hemorrhage, or a subdural hemorrhage? So now to understand this, you will understand this is first a CT image because the bone is hyperdense. The bone is white or bright. You can see that there is similar hyperdense content in the subarachnoid spaces. So there is SAH. It is not in the parenchyma. It is not extradural or subdural. It is in the subarachnoid spaces. And you can see an appearance that has been likened to a very morbid finding called the star of death. Okay. So this is a subarachnoid hemorrhage. Your answer is a subarachnoid hemorrhage. When you're looking at hyperdense content within the parenchyma, you're looking at an intraparenchymal hemorrhage. you can perform a CT angiography in different case scenarios, which will show you multiple serpiginous vessels and probably a nidus. This becomes an arteriovenous malformation. All right. Once you've finished an arteriovenous malformation, for further confirmation and for therapeutic indications, you can perform a digital subtraction angiography, also called a DSA. That will give you exquisite vascular delineation of the nidus, the feeding vessels and the draining vessels. And if feasible, you can also perform a procedure. So this can become a both diagnostic and therapeutic indication. So an AVM can be tackled with a DSA and subsequent endovascular management. All right. Few of the other examples. You will notice here that there is something outside the brain parenchyma. It is not within the neuraxis here. This is an extraaxial collection. Extraaxial. Similarly, you notice another collection here which is hyperdense relative to the brain and is also extraaxial. So both of these are extraaxial collections. You notice that one looks like an idli, one looks like an appam, or like a banana and a lemon. When you see this appearance, you are looking at an SDH, a subdural hemorrhage, and an EDH, or an extradural hemorrhage. So both of these are intracranial, they are within the cranial vault, but they are outside the brain parenchyma. So they become extraaxial. On the other hand, you notice something that's inside the cranium, but not outside the parenchyma. It is inside the parenchyma here. This becomes an intraparenchymal hemorrhage. Similarly, when you have hyperdense hemorrhagic content in the subarachnoid spaces, this becomes a subarachnoid hemorrhage. This becomes a parenchymal hemorrhage or a hematoma. All right. So these can be caused because of aneurysmal hemorrhage, hypertensive bleeds, or hemorrhagic strokes rather, or trauma. All of these can be seen in, these are most commonly seen with trauma. So SAH can be in trauma or in aneurysmal rupture. And a parenchymal hematoma can be because of hypertension, trauma, a post-surgical status. All right, so these are all the various causes and various clues in your STEM that you can use to arrive at your answer. Another question is asking you, in an elderly woman with known myasthenia gravis, old lady with known myasthenia gravis, what is the likely diagnosis? She's also been said to have facial congestion, dilated neck veins, and breathlessness. So she has some SVC obstruction. What is her likely diagnosis? So we've taken a CT at a relatively lower level, which shows a soft tissue density lesion in the anterior mediastinum, extending inferiorly. On the other side, it would extend to compromise the SVC and give you all the symptoms that the lady has. If you're looking at a lipoma is going to be fat attenuation, something like this fat over here. It's going to be uniform hypodense lipomatous tissue. When you're looking at an ectopic thyroid, that thyroid is going to enhance. Now we know that there is hyperdense material which is contrast inside the lumen. There's contrast here, there's contrast here, there's contrast in these veins. You know that this is a contrast enhanced CT. Thyroid tissue which is ectopic should enhance. All right, so it will enhance. This is thyroid tissue. All right, normal thyroid and ectopic thyroid will enhance. A germ cell tumor can also enhance, but a germ cell tumor like a teratoma can have calcifications and other characteristics. So our answer here, especially given the fact that this is an elderly woman with myasthenia gravis, that is your clinch word or your buzzword, your answer becomes a thymoma. All right. An infant has presented to you in the emergency room and a scan has been done. This is a 4-week baby, and an ultrasound abdomen shows you the given finding. So this is your finding. What is your probable diagnosis? Is this a sigmoid volvulus? Is this duodenal atresia? Is this an intussusception, or is this CHPS, which is congenital hypertrophic pyloric stenosis? Now, when you look at a volvulus is going to be a gas-filled twisted loop of bowel. That can be difficult to pick up on an ultrasound. So a volvulus is going to be, likened to a coffee bean sign. And this is on an X-ray of the abdomen or an abdominal radiograph. Similarly, an intussusception, you can get an ultrasound, you can get a CT, a barium image, or you can get a X-ray. So this is again a form of intestinal obstruction, and you're not going to get a picture that looks like this. In duodenal atresia, now the buzzword for a duodenal atresia or a DA is a double bubble sign. So now this can be seen as early as in the intrauterine period. A double bubble can be seen, and You are not seeing something like that here. So essentially, when you take the stomach and the duodenum is occluded. So you get a dilated proximal duodenum and you get a dilated stomach. These are the two bubbles that you see in a double bubble. Here you have what's called a CHPS. So you have thickened hypertrophic muscle of the pyloric canal or the pyloric sphincter. You can have some protrusion of the redundant mucosa back into the lumen, and you will have a gastric obstruction. So there are specific ways in which you will assess for this in the outpatient or the ER to rule out congenital hypertrophic pyloric stenosis, which is your answer in this case. So what you see is a very hypertrophied muscle, and you also see mucosal protrusions. All right. So an infant has presented with respiratory distress and he has a history of recurrent respiratory infections or recurrent LRTIs. Now, based on the imaging findings, you've been asked to give a diagnosis. Is this a lung abscess? Is this a congenital malformation of the airway? Does this child have a congenital diaphragmatic hernia, or is there a pyoneumothorax? So we look at the options given to us. We have a plain radiograph of the chest where we see on the right side a thick-walled air-filled cavity which has an air fluid level, probably because of infected material, infected fluid or hemorrhagic content. So this is what we would call a lung abscess. You have a thick, sometimes a shaggy wall, especially when seen on CT, and this patient is going to have some sort of infective history. We did see that in our case, but it did not look like this finding. The other X-ray that you have is a whole bunch of mottled lucencies, some of which are resembling bowel, seen in the inferior aspect of the right lung, or rather the right lower zone. So this is the upper zone, the mid zone and the lower zone. In the lower zone, you're seeing this. There is some obscuration or loss of silhouette with the cardiac border, and this is actually a diaphragmatic hernia. So a Morgagnian or a Bochdalek hernia can be seen congenitally. So these are the different forms. So here you see a diaphragmatic hernia, TH. So you've seen a lung abscess here. Now, when you're looking at a pyoneumothorax, you will have pus, pyo, and you will have air in the pleural space. So you will see an air fluid level and you will see the pus content. All right. So you have different components to this infected collection, and that's why you call it a pyoneumothorax. All right. So you have air and pus in the pleural space, which gives you a classic finding. Then you have multiple air-filled spaces which kind of resemble the one that we have. Now these can get repeatedly infected and therefore formulate or rather constitute the diagnosis of a congenital malformation of the airway. So there are multiple dilated air spaces which can get infected. Here you can see an infected fluid level, and here in this plane we see one large air-filled space. So not a lung abscess, not a congenital diaphragmatic hernia, not a pyoneumothorax. So if you take a pleural space and you fill it with pus and air, so you'll have air on the top and pus at the bottom. Pyoneumothorax is not the answer that we have here. We are looking at a congenital malformation of the airway. All right. So a young individual has presented with nasal polyps, rhinosinusitis. An X-ray, endoscopy and CT have been done. All these images have been given to you and you've been asked for a diagnosis. Is this Young syndrome, Kartagener syndrome, Churg-Strauss or cystic fibrosis, abbreviated as CF? So your first image is over here. Note that your marker is on the left. You have air under the left hemidiaphragm. There is a shadow here. Your heart appears to point to the side not marked as left. Your second image is an endoscopy image. So this is a nasal endoscopy. All right. Nasal endoscopy, which is showing you polypoidal mass marked in this term P. This is the choanal mucosa, the choana, the various other structures. And you also see a sinusitis kind of picture here, maybe polyps in the nose. You have mucosal thickening in the maxillary sinuses, and your answer therefore becomes a Kartagener syndrome. You have situs inversus because your side has been established. Your gastric air bubble or fundic gas shadow is on the same side as the heart, which is both on the right side, not on the left side. So left side is here, it's not on that side. You have situs inversus, you have polyps in the nose, and this is Kartagener syndrome, not the others. All right. Your next one is an antenatal ultrasound image. So this has been done at approximately 8 or subsequent weeks. You've been asked to find out whether there is anencephaly, hydranencephaly, a meningocele or an encephalocele. So we look at what these look like. This is a CT image, obviously postnatal. This has not been taken antenatally. You notice that the calvarium is ossified. You see the fontanelle spaces, and you notice that there is parenchyma at the back, but this entire space anteriorly is filled with fluid. So, absence of brain and encephaly. There is some brain tissue present posteriorly, and there is a whole lot of fluid in the cranium. This becomes hydranencephaly. All right. You have a baby. This is a newborn. You notice that in the region of the lower dorsal lumbar spine, you see a exposed, mass of tissue, and this becomes a meningocele or a neural tube defect. All right. So this becomes a neural tube defect, which can be open or closed, open in this case. So your next image becomes a large swelling protruding, appearing to have its origin at the occipital region. All right. So when it has an occipital region like this, when you perform cross-sectional imaging and there is brain tissue inside this, brain tissue, CSF, anything, comprising the neuraxis or the neural elements has come out, this becomes an encaphalocele. All right. So your answer then becomes anencephaly by exclusion. So if you look at this image, you notice the eyes, which are hypoechoic or anechoic here, which are widely spaced, all right, what's called a frog eye appearance, and you have naked or exposed neural tissue sitting on the top, all right. So this condition lacks the cranium. So because the growth signals from the cranium are absent, because of its absence, the neural tissue is not going to develop properly, and you're going to have a baby with widely spaced bulging eyes like that of a frog and exposed neural tissue without a calvarial covering. Your next question is a match the following question. You match the answer with the correct number. So this is purely based on radiological anatomy, and you've been asked what are 1, 2, 3 and 4. Arch of the aorta, the trachea, the esophagus and the superior vena cava. So we'll break this down in terms of its appearance. First, this is a CT image. This is in the axial section, and this is what we call a lung window. So you can actually make out details of the parenchyma on both the sides here. This is what we call a lung window. So when you look at the various anatomical structures, you have arterial, venous, and you also have conducting airways, and you have the lung parenchyma itself. The ones pointed out here are, number 1 is a lucent area. It is black. The air outside looks black, the air in the esophagus looks black, and the air in the parenchyma looks black. So these two air-filled structures are the trachea and the esophagus. All right. So the trachea is here and the esophagus is here. All right. The other two structures appear to be relatively dense. They are more white on this given image. Of course, the actual detail is going to be seen on what we call a medius renal or a soft tissue window. The lung window that we see here is primarily for lung parenchyma, but we notice that there is one structure going from one side to the other, sort of like an arch, and the other structure appears to be a single round circle in this particular image. So what we're looking at is a lung window. This is the trachea. Number 1 is the trachea, number 2 is the esophagus, number 3 is the arching structure going from one side to the other. So this becomes the arch of the aorta. All right. And the structure left behind is the SVC, which is going to be on the opposite side, traveling towards the right atrium. Right. In your next image, you have to identify the diagnosis from the CT scans. Is there a PUJ obstruction? Are there renal cysts? Is there a renal tumor, or are we looking at a multicystic kidney? So the image given to you is something like this. You can see this is the area of the right kidney, that's the area of the left kidney. All right, and here you can also see that there is something happening on the left side in a different patient. So this is patient B, this is patient A. So your option has been asked to you. All right. So when you look at this image, you notice that there is a hypodense. So these are all CT images. This and this. They are all CT images. This one is an ultrasound image. You notice that there is a hypodense structure which is not enhancing. This is contrast enhanced CT. There is no enhancement of this structure. This structure has a fluid density and is therefore a cyst. Here you notice that the left kidney appears fairly normal, but on the right side there is a large heterogeneous mass. All right. So this thing will enhance to a relative degree less than the kidney, and this becomes a renal mass or a tumor. All right. So this is a renal tumor. Here you have another CT image in the axial section. You notice that there is some contrast excretion on the right side, there is excretion into the collecting system. On the left side, like we saw in our first image here, we see multiple hypodense structures in the kidney. So there are cysts, yes, but there are multiple cysts. So this is a multicystic kidney, sometimes also called multicystic dysplastic kidney. All right, it won't really function. There is no excretion of contrast material into the collecting system because there is no functioning parenchyma. The entirety of it has been replaced by cysts of various sizes. The last image is an ultrasound image, again showing multiple anechoic spaces. So these are multiple cysts and seen in multicystic kidneys. All right. So your answer then becomes a PUJ obstruction. So if you have a kidney like this, you have the collecting systems. All right. You have the collecting systems coming out here and forming the renal pelvis, getting down into the ureter. When this gets occluded, what happens is you have a grossly dilated collecting system. All right, the entire collecting system dilates, tapers up to a point, which is the pelviureteric junction. So when there is an obstruction at the pelviureteric junction, you have a PUJ-O. That's a pelviureteric junction obstruction, and your kidney becomes enlarged. The parenchyma becomes thinned out parenchyma, and a grossly dilated collecting system. So there is gross HUN. All right, so that's what you're looking at in a PUJ obstruction. The image given to you is a CT image of the abdomen in the axial plane and with contrast. So this is contrast enhanced CT. You've been asked to identify what the problem is: a choledochal cyst, a gallbladder carcinoma, a cholangiocarcinoma, or a choledocholithesis. So we look at some images. When you have a gallbladder lesion, the gallbladder lesion is going to be situated in the GP fossa, and it can infiltrate into the hepatic parenchyma or the liver parenchyma. Here you see a hypodense mass-like lesion in the liver parenchyma, and you can't see a gallbladder properly. So this is likely to be a GB mass or a GBCA. All right. This is going to be a slow enhancing lesion, and this is a contrast CT. You can see contrast in the vessels. This one is not enhancing as much as the liver parenchyma next to it. So this is a GBCA. On the other side, you see multiple dilated structures in both sides of the liver, in both lobes of the liver, bilobar intrahepatic biliary radical dilation, or what you call IHBRD. So intrahepatic biliary radical dilation is because of a obstructive lesion, either at the primary confluence where the right and the left main hepatic ducts meet, or distal to that, somewhere in the common hepatic or the common bile duct. So you have a cholangiocarcinoma. All right, so cholangio is what you have here, and this gives you bilateral IHBRD, bilobar IHBRD. This image is what you call an MRCP image. This is an MRI image of the abdomen. You see that the fluid-filled structures, so the biliary radicals and the gallbladder, are going to be significantly bright. So this is what we call a heavily T2 weighted sequence, T2 weighted image. All right, so this is a heavily T2 weighted image to suppress other structures and highlight fluid structures. We notice that in the expected location of the common bile duct, we have a large calculus here. All right, a large filling defect, and our answer therefore becomes a choledochal cyst by exclusion. You don't have a gallbladder carcinoma. There is no cholangiocarcinoma. There is no choledocholithesis. You have a large, well-defined, smooth, non-thick-walled cystic structure. Okay, it is just under the liver. It's abutting the kidney, and it is along the undersurface of the liver, pushing the pancreas a little to the opposite side. This becomes a choledochal cyst. Now, another common question that you can expect is what you call the Todani classification. All right, so this aims to classify choledochal cysts as, you know, this is a normal cyst, this is a type 1. So where you have a fusiform dilation of the common bile duct. You can have a diverticular or an outpouching like diverticulum. You can have a choledococele right at the end, at the insertion or termination. You can have a dilation. You can have both extrahepatic and intrahepatic cystic dilations, being type 4, and you can have finally exclusively intrahepatic. All right, exclusively intrahepatic dilations of the biliary system. They are not seen on the outside of it. This is called Caroli disease. All right, so these are the different types that you can get in biliary dilation classified by the Todani classification. Okay, so the next one is pretty simple and straightforward. You've been asked to identify the condition associated or represented in the images. Are you looking at a CCP, chronic calcific pancreatitis? Is there mesenteric calcification? Is there a horseshoe kidney, or are there jejunal enteroliths? So we'll take a look at these images. The first one is an axial CT image through the abdomen. You notice that this kidney is extending on both sides of the midline with an area of bridging tissue between. This is very clearly an anomaly called a horseshoe kidney. All right, a horseshoe kidney, normal renal parenchyma extending across the midline with anteriorly facing collecting systems. All right, so the pelvis faces anteriorly or anterolaterally, as you would call it. In another CT image, you see the hyperdense bone. So therefore, this is a CT. In the jejunum or in a loop of bowel, you notice a hyperdense structure. A hyperdense structure like a stone within the bowel is called a lith. Any stone is called a lith. Urolith, choledocolith. Okay, you can also have an enterolith. So an enterolith is a stone within the lumen of the small intestine. So here, if this was the jejunum, this becomes a jejunal enterolith. On another axial CT image, axial CT, there is contrast in the lumen. So this is a CECT. We notice that there is an area of calcification. So when you notice this, in the mesentery, there is calcification. There may be some soft tissue, some speculations sometimes. This becomes a mesenteric calcification. All right. So what you've been asked to identify is which of the following conditions. We've ruled out mesenteric calcification, a horseshoe kidney, and a jejunal enterolith. What we see on this radiograph is multiple foci of calcification extending in the upper abdomen from the midline, or rather sometimes from the right to the left, going in an upward fashion. All right. So this becomes a sequel of chronic calcific pancreatitis. So the pancreas is an organ that is somewhat oriented this way. All right. So when the pancreatic parenchyma undergoes calcification, you can get a chronic calcific pancreatitis, the image of which will look like either one of these. All right. So this is CCP, or chronic calcific pancreatitis. Next up, we have a 6-year-old child. Now this 6-year-old child had seizures. Midazolam was given and the seizures subsided. All right. Some blood investigations and a lumbar puncture was done. An MRI is done next. They are asking you for your next best investigation or your investigation of choice. Now, MRI for intracranial pathology is always the investigation of choice. Your answer is going to be along those lines is what you have to think. So they've asked you, is this a PET scan, a CB-NAT of the CSF, an ocular B scan to be performed, or you perform an MR and spectroscopy. This is the child that's been given to you. You notice that this is the left, this is the right. On the right side, you have a large peripherally enhancing lesion. So this is a ring enhancing lesion or a peripheral rim enhancing lesion. All right. So when you see this kind of pathology, you have certain diagnoses. When you have a large pathology, you can actually assess the content or the nature of what is inside the collection. To do this, we use what's called an MR spectroscopy. And what we find here is we get a lipid or a lactate peak. So when we get a lipid lactate peak, we are looking at necrotic tissue, and this becomes an abscess. A peripheral enhancing lesion inside the brain parenchyma with a lipid lactate peak of its content is going to be best depicted by an MR spectroscopy. What we're looking at is a brain abscess. So your question is two-pronged. One, what is your diagnosis? And two, what investigation are you going to do, or what special test are you going to do, which is going to help you establish the diagnosis. You found out that this is intracranial, so an ocular B scan, a CSF study, or a PET may not necessarily be the most ideal. You already have the child on the MRI table. Do an MR spectroscopy. It's related to your current diagnosis of an abscess. So you do a spectro, an MRS, and you find out that this is a abscess confirmed by a lipid lactate peak. You've been given a mediastinal mass on a chest X-ray. The measured Hounsfield units of the mass reveal -70 HU. So you have to now find out which of the following lesions is in your diagnosis. Is this a thymoma? Is this a parathyroid adenoma? Are you looking at a teratoma, or is this a lymphoma? So now this is our lesion. We notice that there are multiple areas of hypodense or fat attenuation here and here. There is some soft tissue attenuation here, and there are some calcifications here. All right. You also notice that there is contrast inside. There is no significant enhancement in our lesion. the fat inside is, similar density to this fat. So you know that this is a fat attenuating lesion. Minus 70 is in the range for fat. That's the normal HU for fat, as in it's in that range. When you look at some of the other images, again axial CT image, you see a soft tissue density mass lesion in the anterior mediastinum. Now, this lesion becomes a thymoma. You look at a contrast enhanced image here. So, this is in the neck, contrast enhanced CT, and an axial view has been given to you. You look at the thyroid gland on either side of the trachea. This round structure here is the trachea. You see a well-defined enhancing structure posterior to the left lobe. So, this is the left lobe of the trachea, of the thyroid gland, because this is the left and this is the right side. You see that it is smooth, it does not have calcifications, it does not have areas of necrosis. This becomes a parathyroid lesion or a parathyroid adenoma. Alright, so you have a parathyroid adenoma. Now, if you had a lesion which was soft tissue density in the neck, large lesion, homogeneously enhancing, that becomes a lymphoma. I have drawn this for reference. It's not there in this case. This is a separate drawing. Alright, so this is a lymphoma, a teratoma, a PTH adenoma, and thymoma. We've ruled out all of these three. What we're left with is a teratoma. So, a teratoma or a germ cell tumor has multiple different components. You can have soft tissue, you can have fat, and you can have calcium. Alright, all three of which are present in our case. We have soft tissue, we have fat, we have calcification. We're looking at a teratoma in the anterior mediastinum. Good. So now you have to identify the image, or rather identify what modality or what has been given to you. So this can be a very tricky question depending on what options have been given and depending on the coverage. So you've been asked, is this a fluoroscopy? Is this a barium swallow? Are you looking at alkali ingestion or acid ingestion? So has an alkali solution been swallowed? Okay. So when you look at two images, you see that this is an X-ray. Alright, this is not a CT or an MRI. This is an X-ray which has been enhanced by the administration of some sort of hyperdense contrast material. So, this material has been given to the patient to swallow, and you have to find out where this is going. Now, if you notice here, the patient has swallowed. You can see the lower part of the angle of the mandible here. You can see that this is opacifying the esophagus almost till it's the lower part of the neck. In the image given to us in the question, you can see much more of the mandible over here. Over there, you can see that this is outlining what we think is the pharynx, and we don't actually see the distal parts of the esophagus. What you also see is multiple hyperdense or radio opaque structures which are possibly surgical clips. So, surgical clips here, you see a hyperdense content within the lumen of the upper GI tract. So, this is probably the pharynx. Alright, you don't see the distal part of the esophagus. It's present here, it's not present over here. When you have acid or alkali solution, you will have eroded mucosa. The mucosa will get denudated and will ulcerate, and that can be similar in both. Both of them are going to destroy the esophageal mucosa. You're going to have a very irregular pattern of the mucosa. So, not very specific. You can have overlapping imaging findings in both of these conditions. So, what you have to decide is, are you looking at a barium swallow or are you looking at a fluoroscopy? Fluoroscopy is essentially the technique. This is the study that you perform. A barium swallow is this one on the right. This is a barium swallow, and you are left with your answer of fluoroscopy. Okay. So, this you will have to taper your answer to the question that's been given to you. If it's what technique, this becomes a barium swallow. If it's modality, this becomes fluoroscopy. It's basically like X-ray TV. You observe the contrast column going through the intestine. Alright. Moving on to another similar related question. A 66-year-old individual, a 66-year-old lady has progressive dysphagia, difficulty in swallowing for solids along with significant weight loss. A barium swallow has been performed. They've told you this is a barium swallow, and the results are provided. The images rather are provided on the side here. So, based on the clinical presentation and the findings, what is the diagnosis? So, now clinically based on the diagnosis, you have dysphagia, alright? You have dysphagia, you have weight loss, and you have this X-ray. So, we're looking at a barium image which is showing a relatively dilated upper esophagus, passage of contrast distally into the stomach, and a significant irregularity in this area. Alright, so there's irregularity of the esophageal mucosa in the distal aspect. And if you imagine a person here, this would be his shoulder. So, this is what we call a shoulder sign. All right, so there is shouldering over here with significant irregularity in the involved segment of the esophagus. We are looking at a clear-cut case of esophageal carcinoma. So there are several hints in the clinical stem here, and also there is a very suggestive imaging picture. So no doubts about that. When you have diffuse esophageal wall spasms, you will get something that looks like this, like a corkscrew appearance of the esophagus. So DES, diffuse esophageal spasms, or a corkscrew appearance, all right. When you have a, so if you imagine this is the wall of the esophagus, you have a smooth tumor arising in the wall. The barium film is going to outline it and is going to give you this smooth meniscus-like picture. So this is a leiomyoma, all right. So this is a esophageal leiomyoma, or a benign lesion in the wall of the esophagus. Diffuse esophageal spasms we've already seen, and when you have a shelf-like projection in the anterior esophagus over here, so you can see that this is posterior because the vertebral column is here, vertebral column, the esophagus is anterior to that, and in the anterior aspect you have a shelf-like projection. This becomes an esophageal web, all right. So all of our options are sorted. Our answer is a carcinoma esophagus. We've also seen what the other three look like. Okay. So here there's a person, a 40-year-old, who has persistent hypertension, some chest pain and cramping in the legs. This is aggravated or made worse by physical exertion. A chest X-ray was done. There is a specific finding, all right. You have to identify that finding and give the most likely cause for the hypertension. Now, are you looking at a coarctation of the aorta? Is this essential hypertension? Basically, hypertension in an older person without a cause. Is there an aortic aneurysm or is there aortitis? Now, to pick out an aortic aneurysm or an aortitis, you will be given some sort of contrast material, all right. So both of these can be ruled out because this is not a CT, this is an X-ray, and you don't have any form of contrast given into the arterial system. Essential hypertension, older person, you may have an early onset or hypertensive in young in a 40-year-old, but that is not going to have any specific X-ray findings. What we are looking at is a coarctation of the aorta. So the same X-ray given to you here is represented over here. What you see is a figure of 3 sign, all right. So there is an indentation indicating the point of stenosis or coarctation of the aorta. So what you're looking at here is coarctation of the aorta, all right. That's your answer in this particular case. Next up, we have a 44-year-old man. He has abdominal pain, blood-stained stools, and a barium study of the intestine has been done. A specific imaging finding is seen. What is your most likely diagnosis? So, our options are intussusception, volvulus, diverticulitis, and an ulcerative colitis. Now, when you're looking at the bowel, when you have volvulus, you will see a twisting of the bowel on itself. When you have this sort of twist, this becomes a volvulus. Okay, we don't have any such picture in our image over here. When you have a diffusely granular mucosa extending throughout the colon, this is the left, this is the transverse, and this is the right or the ascending colon, you have the entirety of the colon involved with involvement of the sigmoid and rectum. This becomes ulcerative colitis, all right. This granular mucosal pattern is very, very typical of an ulcerative colitis pattern. So that's what we have over here. Now, what we've been given is multiple concentric rings and a bowel loop that appears to have gone inside the other bowel loop. What you're looking at here is an intussusception, all right. For a diverticulitis, a better modality would have been a CT, maybe with contrast. So our answer here is a diverticulitis. You know that you can see multiple loops of the small intestine, and you can see that one loop has gone inside the other. So this is intussusception, where you have the intussusceptum, TUM, and the intussuscipiens or the recipients or the recipient bowel loop. All right, so this is intussusception. Next up, we have a contrast enhanced MR image. So this is a sagittal image. All right, a sagittal image, T1 weighted with contrast. All right, you have a cystic lesion in the suprasellar aspect with calcification on the MRI. They are asking you for the diagnosis. Is this a craniopharyngioma, a pituitary adenoma, a meningioma, or an oligodendroglioma? So we're looking at something that's in the midline, in the sellar, suprasellar, or parasellar regions. These are our areas of interest, and we have multiple different pathologies that can occur in these parts. So if you look at these images, you will see that there is a nice snowman-like appearance. The lesion is sitting in the sella. This becomes a pituitary lesion, all right. a pituitary macroadenoma, is going to have this classical snowman appearance, the head of the snowman being the part of the tumor which is above the sella. The rest of it is going to be sitting within the sella turcica. There is going to be a little bit of a waist between the two. Okay, so like that, this part is above the sella, this part is within the sella turcica. So this is a pituitary macroadenoma. Here you have a large lesion which is enhancing homogeneously, appearing hyperdense on CT and showing relative heterointense signal on T2 FLAIR images. This is a meningioma. Okay, it's a large meningioma in the midline. This has been given because our topic of interest is a midline lesion. All right, here you notice that there are multiple serpent become an oligodendroglioma. This is an oligodendroglioma. All right, so this is a lesion which is going to be seen in the supratentorial or the cerebral compartment and is going to have extensive calcification. So our answer here is going to be a craniopharyngioma because it is T1 hyperintense. This is a T1 weighted image. The CSF is going to be dark, the gray matter is going to be gray, the white matter is going to be white, and you're going to get a hyperintense lesion in the suprasellar aspect. So if you notice here, this is the pituitary, this is the stalk, you have a hyperintense lesion sitting above that. This is a craniopharyngioma. So craniopharyngioma, pituitary macro, meningioma, and an oligodendroglioma. All right, so these are your answers over here. How do you monitor personal radiation dose? So personal radiation dose, either a TLD badge, a collimator, a linear accelerator, or a grid. Your answer here is the good old TLD badge. The others are basically used for other image acquisitions, collimators and grids. A linear accelerator is not used to monitor personal radiation dose. So here, this is a control. You have a window which allows radiation, you have various filters, and these things are assessed. Basically, there is a badge inside, a film badge inside, which is assessed once in every 3 months for the cumulative radiation dose. All right, so you can use components like lithium fluoride, which store the radiation basically and can be heated to give off their radiation that has been stored, and you can get a 3-monthly readout of how much radiation the person has been exposed to. All right, so the ultrasound appearance of the saphenofemoral junction showing the common femoral vein, the common femoral artery, the great saphenous vein. What is this sign called? Is this a Mickey Mouse sign, a string sign, a Taylor sign, or a stemmer sign? So we look at all these various signs. This is essentially your common femoral vein, the great saphenous vein, and the common femoral artery. You already must be having an inkling as to what sign this represents, but we will look at all of them sequentially. We notice that the string sign, as we've seen earlier, resembles a string seen in the terminal ileum in Cox and in Crohn's disease. The Taylor sign is basically ballotability or movement perpendicular to the mesenteric attachment, and this is seen in chylolymphatic cysts of the mesentery. You also have the stemmer sign, where the normally pinchable skin over the dorsum of the foot cannot be pinched when there is significant edema in the foot. This is called stemmer sign. And finally, you have your diagnosis, which is the Mickey Mouse sign. All right. So Mickey Mouse sign is seen at the junction of the GSV and the CFA and CFV in the femoral. All right. So our next question is in a 25-year-old individual with spinal tuberculosis, low-grade fever, and dull backache with persistent flexion of the left hip joint. Left hip joint movement is painful. Which of the following structures, or label the following structures that may be involved? So when you look at the anatomy over here, number 1 points out to the anterior abdominal wall, or this is in the lateral aspect, but basically the abdominal wall. We know that the abdominal wall in this region has 3 muscles: the external obliques, external and internal, and the transversus abdominis. The innermost layer being the transversus abdominis. Number 1 is the transversus abdominis. All right, transversus abdominis. Number 2 is in the paraspinal region. So this is the vertebral column, and this is the muscle indicated on the left side. We know that this muscle extending onwards to flex the hip is the psoas major. All right, this is the psoas major muscle. Number 3 is in the adductor compartment. So this is the femur. This is in the adductor compartment of the thigh. Number 4 is in the gluteal region. This becomes the gluteus muscle. All right. So in our options, the one that we want is going to be the option number 2. Option number 2 is involved, and this is going to be the psoas major muscle. So you identified the anatomy that is at play here, and you've also got your hint from the question, which is persistent flexion of the hip joint. You know that number 2, the psoas major, is a hip joint flexor, and therefore that is your answer in this case. All right. So in a 10-week-old child with fever, cyanosis and fatigue, a chest X-ray has been performed and given to you. Based on the clinical presentation and findings, what is the most likely diagnosis? Are you looking at a TAP VC, total anomalous pulmonary venous communication or circulation? Are you looking at TOF, tetralogy of Fallot? Is this a TGA? Are the great arteries transposed, or are you looking at a pericardial effusion? Okay, we look at these images. Now, there are multiple signs and very, commonly used buzzwords in radiology and multiple choice exams. You have what's called a snowman sign. Snowman sign. So here you have two bulbous structures on either side with a waist in the middle, forming the appearance of a snowman. You also have a boot-shaped appearance over here, and you have a egg. This looks like a potato, but an egg on a string. So now you know that an egg on a string is going to be seen in TGA. All right. So this is transposed great arteries because the crossing is missing. You have a boot-shaped heart seen very classically in TOF. The apex of the heart is upturned like this because of a large right ventricle. You have the snowman sign, which is seen in complete TAP VC, total anomalous pulmonary venous communication. And you have a pericardial effusion where you have a dilated globular heart, which resembles a leather bottle from the olden days used to carry water and other liquids. All right. So this is a these are the various forms and signs that you can get. The one that we have closest resembles a snowman. This is a total anomalous pulmonary venous communication. All right. That is our answer in this case. So, in a patient with a motor vehicle accident, he has a history of a motor vehicle accident. He's been brought to the emergency room a few hours later. So, he has a stable GCS. So, his cranium and his brain parenchyma is most likely intact. He has reactive pupils. He has tenderness and bruising over the left lower chest wall. All right. There are petechiae, and he has severe tenderness in the left hypochondral region. His blood pressure is about 90/50. What are you going to do next? What is the best diagnostic test? Are you going to do an X-ray, a FAST, a diagnostic peritoneal lavage, or a CT? Now keep in mind, this person is slightly, the blood pressure is on the lower side. We need to check what his normal was. His GCS is intact, so we probably don't need to do a CT brain or the abdomen. We need to monitor his vitals. So his X-ray is not going to be performed here because at the most you'll see maybe rib fractures, or you may not see anything. You may not want to subject the patient to radiation unnecessarily, and therefore definitely not a diagnostic peritoneal lavage, which is an invasive procedure. You're going to poke a needle into the abdomen and see what you find. The one with the least risk, easiest accessibility and absence of radiation is going to be your ultrasound. So you're going to perform a focused assessment, sonological assessment in trauma. All right, so that's what you're going to do. You're going to perform a fast scan for this patient. All right, focused assessment in sonology in trauma is going to give you fluid in the abdomen, maybe solid organ injury. If you have fluid with internal echoes, you are looking at hemoperitoneum, and you have to further investigate the patient, probably with a CCT abdomen or some other modality. All right, so here a patient presents with abdominal pain and distension. An X-ray is performed, revealing multiple dilated bowel loops. So based on the radiographic findings, which segment of the bowel is involved? Is it the jejunum, the ileum, the duodenum, or the transverse colon? Now you have to remember that from the stomach all the way through the intestine, all right, through the large intestine. Okay, I'm drawing a very rough schematic here, sigmoid and rectum. Wherever you have the point of obstruction, everything before that or upstream to that gets dilated. So if I have a gastric outlet obstruction, the stomach will dilate and the patient will start vomiting out gastric content. If I have an ileal obstruction, the jejunum, duodenum and stomach will dilate. You will have again retrograde expulsion of content. If I have a sigmoid or a rectal obstruction, the entire large bowel and to an extent the small bowel will also start getting obstructed depending on the grade of the obstruction. So look at the X-ray given to you and try to figure out which bowel is involved. So here, when you have the small bowel, you will have multiple folds of the mucosa, which you will identify and remember as valvulae conniventis. So when you have valvulae conniventis, you are looking at a jejunum that's been dilated. So you have gross dilation of the jejunum. The point of obstruction is likely in the terminal jejunum or in the ileum. Alright. So if you don't have ileal dilation, you can rule out something in the colon, either the transverse or distally. And if you had involvement of the jejunum, if the occlusion was in the jejunum up here, in the duodenum up here, you wouldn't have so much dilation of the jejunal loops. It would be before that itself, and you won't have too much air and content appearing in the segment distal to the duodenum. So if you have an ileal, proximal or mid-ileal obstruction, you will have large amount of jejunal loops which are dilated. Alright. Another example of a small bowel dilation. So here you see some segments of featureless bowel. Here you see mucosal folds, and you can also see large bowel here with its haustra. Alright, so different haustra in the abdomen. This could be a large bowel obstruction. Similarly, when you see haustrations like these folds of along the wall, this becomes large bowel obstruction. And remember the rules: when you have 3 centimeters, 6 centimeters and 9 centimeters. When you have small bowel dilated more than 3 centimeters, that is obstruction. Similarly for the large bowel and for the cecum. Alright, so these are your cutoffs to discern whether there is dilation in the or obstruction in the bowel or not. So our answer here became either ileum, or if the question was played out appropriately, this could be a jejunum, if in only the proximal jejunal loops and the duodenum and stomach were dilated. So here we'd assume ileum because all the jejunal loops are dilated. Alright, so in a child with an acute lymphoblastic leukemia, ALL, he undergoes prophylactic irradiation before receiving a stem cell transplant. So you want to wipe out all of his native marrow before giving him new marrow or transplanted marrow. Which of the following is least likely to be affected by this treatment? Now for this you need to understand that radiation, especially the ones that we use diagnostically and therapeutically, are ionizing radiation. So ionizing radiation tends to affect rapidly dividing cells or highly metabolically active cells. Alright, so these cells are obviously seen in the gonads. Good. You will see them in the mucosa of the GIT. So in the GIT, in the mouth, in the respiratory tracts, all of those areas in the GIT. And you will also see them in the bone marrow, obviously. So that's exactly what we're trying to wipe out. So we know that these cells are sensitive, so we are using this to wipe out the bone marrow and irradiate it. That's why we say prophylactic irradiation. We're giving ionizing radiation to wipe out the marrow. Neurons are stable cells. They are not rapidly dividing. They are, relatively stable throughout a long period of time. So not the gonads, not the intestinal epithelial cells, and not precursor cells or bone marrow cells. Our answer here, the ones that are least likely to be affected by radiation, are neurons. Alright, so in this brief overview of questions that have appeared in previous years, I hope you've understood the various types of questions that you can get, and also the ways in which you would approach these and arrive at a correct answer. Thank you.